welcome to the deep dive. Today we're getting into a topic that's incredibly common, but actually has quite a bit of depth to it. Adult urinary tract infections.
Absolutely. It's definitely one of those areas where having a solid grip on the essentials is, well, essential. Whether you're dealing with it clinically or just want to understand a really prevalent health issue.
Totally agree. We've got these revision notes right here, and our aim today is to take all this info on adult UTIs and break it down into something really clear, high yield,
Yeah.
perfect if you're revising or just trying to get properly informed.
And we're sticking strictly to what's in these notes, right? Just exploring the information provided.
Exactly. Okay, let's unpack this then, starting right at the beginning, based on this material. What exactly is a UTI?
Well, at its core, it's an infection somewhere in the urinary system. These notes tell us it's usually bacterial.
Right, usually bacterial, though it does mention fungi or viruses as rarer causes.
Yeah, and it can be lower down, think bladder, urethra, or it might affect the upper system, so kidneys and ureters.
Okay, and the source mentions a few specific types we should probably define.
It does. It lists bacteria first that's just having bacteria in the urine, and crucially, it might not cause any symptoms at all.
Okay, symptomless bacteria.
Then you've got your lower UTI, often called cystitis if it's mainly the bladder, and upper UTIs, that's pyelitis or pyelonephritis, meaning the kidneys are involved.
Got it. The notes also define recurrent UTI. That sounds important clinically.
Yeah, the definition given here is 2 or more infections within 6 months or 3 or more in a single year.
Okay, U2 in 6 months, U3 in a year. And there's another distinction made, uncomplicated versus complicated.
Exactly. Uncomplicated is basically in someone with a normal urinary tract, normal kidney function. Complicated means there are underlying factors, things that make the infection more likely to stick around or, come back.
Right. So moving on to etiology, where do these infections actually come from, according to this material?
Well, the Knights are really clear on the main culprit. It's overwhelmingly Escherichia coli.
Which normally lives where? Digestive system, right?
Precisely. That's its usual habitat. And that link is key.
Because that explains how it usually gets into the urinary tract.
Yeah, the primary route mentioned is bacteria entering via the urethra and then traveling upwards. Ascending infection.
But not always.
The source does also mention it can sometimes enter the bloodstream and get to the kidneys that way, though the urethral route is the main one.
Okay, E. coli is number 1. What other bacteria are listed as common causes?
Klebsiella, Proteus, and Enterococcus are mentioned as other key players.
And we already touched on fungi and viruses being rare.
Yes. The notes also list some less common ones. Enterobacter, Escherichia, Pseudomonas, Staph aureus, Candida albicans.
Quite a few others then.
And there's a specific point made about Streptococcus being rare in uncomplicated UTIs, but that group B strep can cause issues for some women.
Okay, now this next section on risk factors looks really interesting.
Yeah.
And quite long in the notes. It seems like a lot of things can influence someone's chances of getting a UTI.
It really does highlight how multifactorial it can be. Gender is a big one mentioned right away. Females are at higher risk.
And the reason given is the anatomy.
Yeah, the shorter female urethra basically provides an easier path for bacteria. Simple anatomy, big difference.
Makes sense. What else is on this list?
Sexual activities mentioned, including new partners. Menopause comes up too, related to hormonal changes.
Okay. And physical issues.
Definitely. Any urinary tract abnormalities or blockages, it specifically calls out prostatic obstruction in men as a factor.
And something very relevant in healthcare settings. Catheters.
Oh, absolutely. The notes flag urinary catheterization as a significant risk factor, big source of infections.
What about underlying health conditions?
Yes, a weakened immune system is listed. Pregnancy also increases risk, again tied to hormonal shifts. And diabetes is mentioned. It apparently alters the local flora and can promote E. coli growth.
Interesting. There's also anatomical or even genetic factors.
Yep. Plus, recent instrumentation like having procedures on the renal tract, incomplete bladder emptying is another one.
And, maybe surprisingly, antibiotic use itself.
Yeah, it seems counterintuitive, but using antibiotics can sometimes disrupt the normal balance of bacteria, potentially making it easier for E. coli to take hold.
Right. Spermicide use is also listed, and being in healthcare facilities, generally institutionalization.
It's a pretty comprehensive list, isn't it?
It really is.
If you're trying to revise this, maybe grouping them could help. Like, think anatomical or physical factors, then maybe lifestyle or activity-related ones, then medical conditions, and finally, things related to procedures or healthcare settings. Sort of helps break it down.
That's a good tip. Grouping definitely helps with recall. Okay, so we know the what and the why, but how does the infection actually take hold? The pathophysiology described here.
Right, so the process starts with bacteria colonizing the area, often near the urethra, and then they start to multiply.
And they don't just hang around loosely.
No. A key step mentioned is adherence. The bacteria actually stick to the lining of the urinary tract.
And that's what triggers the problems.
Exactly. That adherence kicks off the body's inflammatory response, and it's that inflammation causing the swelling and irritation that leads to many of the symptoms people experience.
And the usual suspects we mentioned, E. coli, Staph saprophyticus, Klebsiella, Proteus, they're the ones doing this colonizing and adhering.
Yeah, those are the common ones involved in this process, according to the notes.
And while the main route is up the urethra.
The notes also remind us that infection can be introduced via catheters, during surgery, other instrumentation, or even spread from the bloodstream, particularly mentioned for people who are immunocompromised.
Now, this next bit is absolutely crucial for anyone working clinically. Differential diagnosis. What else, according to these notes, could look like a UTI?
Yeah, this is important because UTI symptoms can overlap with quite a few other conditions. The list here includes things like STIs, sexually transmitted infections,
Okay, STIs. What else?
interstitial cystitis, bladder stones, kidney stones are all mentioned.
Hmm.
Also, urethral syndrome in women.
And specifically for postmenopausal women.
Atrophic vaginitis or urethritis again, linked back to those hormonal changes.
Makes sense. Any infections elsewhere?
Yes, various genital tract infections can cause similar symptoms. The notes list candida, which is thrush, herpes simplex, chlamydia, gardnerella.
And for men,
An enlarged or inflamed prostatitis is a key differential.
then there are more serious things mentioned.
Right, like an acute abdomen or sepsis. And critically, something we need to highlight again, especially for older adults, an acute confusional state or delirium. Sometimes that might be the main sign.
Wow. So if someone presents with, say, painful urination and maybe some lower abdominal pain, based only on what we've covered so far from these notes, it's hard to immediately distinguish a simple UTI from, say, a bladder stone, isn't it? Both can cause pain there.
Exactly. You'd need more information from the history, wouldn't you? Maybe the type of pain, other associated symptoms, past history. It really highlights why the next steps, the investigations, are so important. You have to keep these differentials in mind.
Okay, zooming out a bit, epidemiology. How common are UTIs, particularly in the UK context, described in this source?
They're described as very common, both here and worldwide. And as we noted, significantly more prevalent in females.
And they have a big impact on healthcare services.
Definitely. The notes state they're a major reason for GP visits and contribute significantly to healthcare costs in the UK.
And in hospitals.
A huge contributor to hospital-acquired infections, the figure given is 23% in the UK, often linked back to those urinary catheters we talked about.
Right. And for women, it's often not just a one-time thing.
No, the notes say acute UTIs affect up to half of all women at some point, and the recurrence rate is pretty high, 20 to 30%. They also become more common in older women.
And that specific category, catheter-associated UTIs.
A prevalence of 8.5% is cited in this material.
The source also talks about asymptomatic bacteriorrhea, bacteria without symptoms. Who gets that?
It's noted as common in several groups: pregnant women, premenopausal women, elderly individuals, people with diabetes, and those with spinal cord injuries.
And the key point about treating that.
Yeah, this is crucial and comes up again in management. Generally, treating asymptomatic bacteriuria is not recommended based on these notes, except in specific groups, notably pregnant women.
Okay. And what about men?
UTIs are rarer in healthy young or middle-aged men, but the risk increases with age, other health conditions, being in institutional care, or having a catheter.
And asymptomatic bacteria in men.
Also more common in men over 70 and older individuals in care settings.
So let's get down to the specifics of what a UTI actually feels like or looks like, the clinical presentation in adults.
Well, the symptoms can vary quite a bit, depend on where the infection is and how severe it is. But common signs listed include urgency, feeling like you need to go right now, frequency, so needing to go often, and dysuria.
Dysuria being painful or burning urination.
Exactly. Other classic signs are cloudy or foul-smelling urine and discomfort or pain in the lower abdomen.
What if the infection has gone higher up towards the kidneys?
Then you might see symptoms like suprapubic or loin pain, that's pain lower down in the front or in the flank back area. Plus more systemic signs like rigors, those shaking chills, pyrexia, which is fever, and maybe nausea or vomiting.
The notes also mention painful but scant urination and hematuria, blood in the urine.
Yes. And we absolutely have to circle back to that key symptom in elderly patients.
Acute confusion or delirium.
Right. The material really emphasizes that this can be a primary, sometimes the only, presenting symptom in older adults. That's such a high-yield point from these notes.
Definitely one to remember. The notes also give some specific diagnostic criteria for women under 65.
They do. It says diagnosis can often be made if they have 2 or more key urinary symptoms, specifically listing dysuria, new nocturia, waking at night to pee, or visibly cloudy urine, provided you can exclude other genitourinary causes.
And there are warning signs mentioned that might point towards something more serious.
Yes. Signs suggesting pyelonephritis, sepsis, or maybe even cancer include kidney area pain, myalgia, muscle aches, those rigors and fever we talked about, and significant nausea or vomiting.
That's quite a few symptoms. You mentioned mnemonics earlier, maybe for the common lower UTI symptoms.
Yeah, sometimes a simple mnemonic can help lodge things in your memory. You could playing with the letters UTI, maybe. U for urgency, T for temperature, the fever is more upper UTI. I for irritation or increased frequency. Or maybe CYSTIS for cystitis symptoms. Cloudy urine, yikes, pain, suprapubic pain. You get the idea. Just something simple to trigger recall.
Good idea. Okay, so someone presents with these symptoms. How do we confirm it's actually a UTI, according to this material? What investigations are done?
Well, it kicks off with a good assessment, taking a thorough history, asking about previous UTIs, sexual history, recent antibiotics, any known kidney problems, diabetes, immunosuppression, that sort of thing.
And a physical exam.
Yes, examining the abdomen, specifically checking for tenderness over the bladder or kidneys.
Then we move to tests. The quick one is the urine dipstick, right?
Yes, that tests for nitrites, which some bacteria produce, and leukocytes, which are white blood cells indicating inflammation. But there's a really important caveat in the notes.
It is.
It's explicitly not recommended for diagnosing UTIs in adults with catheters. Bacteria are often present on catheters without causing a true infection, so the dipstick isn't reliable there.
Okay, good point. What about looking under the microscope?
Urine microscopy can also detect leukocytes, confirming inflammation.
And the gold standard is the urine culture. When is that needed, according to these notes?
The guidance here says it's needed in high-risk patients if the initial treatment isn't working, or for men presenting with symptoms.
But not always.
Correct. It specifically says it's not generally needed for straightforward lower UTIs in non-pregnant women under 65.
What about imaging? Seeing the kidneys and bladder.
Ultrasound of the upper urinary tract is mentioned, particularly if acute pyelonephritis is suspected. And further imaging might be considered if a fever persists despite 72 hours of antibiotic treatment.
And when should referral to a specialist be considered, based on this source?
Okay. So urgent referral is needed if someone is seriously unwell, like suspected sepsis. Otherwise, consider referral for imaging or cystoscopy that's looking inside the bladder with a camera if treatment fails, if there's a history of kidney issues or blood in the urine persists, if women have recurrent infections despite trying preventive measures, or if men have multiple infections.
Also for men with signs of obstruction or upper UTI symptoms.
Yes, exactly. Referral isn't seen as routine after just one simple UTI in men, but it's considered in these other scenarios.
This also touches on cancer pathways, doesn't it?
It does. The notes reference the NICE Cancer Guidelines from 2015. They mention doing a PSA blood test and a digital rectal exam, DRE, for men who have lower urinary symptoms or hematuria.
And the urgency depends on the type of hematuria.
Right. Unexplained visible hematuria, or hematuria that persists or recurs after UTI treatment, warrants an urgent 2-week wait referral.
Okay. And for older people?
Non-urgent referral for suspected bladder cancer should be considered in those aged 60 or over if they have unexplained recurrent UTIs. It really shows that while UTIs are common, they can sometimes signal underlying issues that need checking out.
Right. Let's move on to management. How are UTIs treated according to these notes?
The core treatment is antibiotics. The choice depends on the likely bacteria, how severe the infection is, local resistance patterns, which is really important, and the patient's history.
What about things like drinking lots of water or cranberry juice?
The notes mention hydration and hygiene advice are often given, but they're careful to state that the evidence for them actually preventing UTIs is limited. Same for cranberry products. The evidence isn't strong according to the source.
Okay, so mainly antibiotics. How does the treatment differ for different people? Let's start with non-pregnant women with lower UTIs.
For them, you follow local guidelines. Often, it's a short course, like 3 days, of trimethoprim or nitrofurantoin. A urine culture is recommended if they're over 65 or have hematuria.
And pregnant women. This seems like a key group.
Absolutely. If they have symptoms, you need to get a urine culture and start treatment right away. Nitrofurantoin, amoxicillin, or cephalexin are listed as options. And crucially, remember the asymptomatic bacteriuria. If found during routine screening in pregnancy, it should be treated with antibiotics after culture.
Got it. What about men?
For men with symptoms, immediate antibiotics are recommended, typically for a longer course, 7 days. Trimethoprim or nitrofurantoin are common choices, and a urine culture should always be sent. Referral isn't usually needed after just one episode.
And catheterized patients. Very specific guidance here.
Very specific. The notes state clearly, do not treat asymptomatic bacteria, only treat if they develop symptoms. If treatment is needed, it's usually for 7 days, and you should consider changing the catheter if it's been in for more than a week.
Okay. And if it's the more serious kidney infection, acute pyelonephritis.
For those cases, hospital admission should be considered. Treatment again follows local guidelines, but often involves a broad-spectrum antibiotic, like a cephalosporin or a quinolone in non-pregnant women. And the course is longer, typically 10 to 14 days.
The notes also provide a bit more detail on the antibiotic choices themselves.
Yes. For those uncomplicated lower UTIs in non-pregnant women, there's mention that you can sometimes delay antibiotics if symptoms are mild to see if they resolve on their own. Options listed again are nitrofurantoin, trimethoprim, fosfomycin, pivmecillinum, or potentially amoxicillin, but always considering local resistance.
And for men, it's immediate antibiotics, culture, often nitrofurantoin or trimethoprim.
Right. And pregnant women, immediate antibiotics, culture using nitrofurantoin or amoxicillin if the bacteria are susceptible, or other options based on local guidance. That treatment for asymptomatic bacteriuria specifically mentions amoxicillin, cephalexin, or nitrofurantoin.
So just to hammer home that key point from the material again, no routine treatment for asymptomatic bacteria in men or non-pregnant women.
Correct. And generally, no routine long-term preventative antibiotics for people with long-term catheters unless they have a history of frequent, severe, or complicated UTIs.
Those durations seem key. You mentioned grouping earlier, maybe a quick way to remember the antibiotic lengths.
Yeah, you could maybe think 3 days for simple cases in women, 7 days for men or symptomatic catheter infections, and then 10 to 14 days for the more serious kidney infections, pyelonephritis. Just a rough guide based on these notes.
Okay, moving towards the end, what's the typical outcome? The prognosis section.
Generally, for uncomplicated UTIs, the prognosis is good. The notes say they typically resolve within a few days with the right antibiotic treatment.
But not always simple.
No, if UTIs are recurrent or complicated by underlying factors, they usually need more investigation and a more tailored management plan to prevent ongoing problems.
And the key seems to be early action.
Yes, the notes stress that early detection and prompt, appropriate treatment are really key to reducing the risk of complications and stopping them from coming back.
And finally, what can go wrong if things don't resolve easily? The complications listed in this source.
Well, the main ones listed are recurrent infections, just keep getting them. Then pyelonephritis, that kidney infection developing from a lower UTI. Sepsis is a serious risk, especially noted in vulnerable individuals.
Can it damage the kidneys long term?
Yes, kidney damage is listed, and in severe or untreated cases, even kidney failure is mentioned as a potential complication.
Are there specific complications highlighted for certain groups?
Yes. For pregnant women, untreated UTIs, even asymptomatic bacteriuria, significantly increase the risk of problems like preterm birth, low birth weight babies, and anemia during pregnancy.
And for men?
Complications can include infections spreading to the prostate gland, prostatitis, or even forming prostatic abscesses.
Okay, so let's try and connect the dots here. We've gone through this dense set of notes, and the picture that emerges is UTIs are super common, yes, especially in women, mostly caused by E. coli bacteria. There's a huge range of risk factors, making some people more susceptible. Diagnosis relies on symptoms, plus tests like dipsticks and cultures, but how you use them varies.
And the treatment, while usually antibiotics, is really tailored. Different drugs, different durations, depending on who has the infection, where it is, and how severe it seems.
It really is quite nuanced, isn't it, for something often thought of as quite simple.
Absolutely. What stood out to me, perhaps, rereading this material is just how significant those hospital-acquired catheter-associated infections are. That 23% figure is stark.
Yeah, that really makes you think. And the point about confusion in the elderly being potentially the only sign, that feels like such a critical takeaway from these notes.
Definitely. And also the whole asymptomatic bacteriuria thing, knowing when not to treat versus when you absolutely must, like in pregnancy, that distinction is vital clinically and clearly laid out here.
So for you listening, whether you're using this to revise for an exam like the MSRA, or preparing for clinical work, or even just wanting to be better informed, hopefully breaking down these notes section by section gives you that clear, high-yield understanding of the core information presented here.
And maybe a final thought to leave you with, drawn straight from this material we've discussed. While UTIs are often straightforward, these notes clearly show they can mimic other serious conditions and can lead to significant complications. It really underlines the importance of that careful assessment and tailored management approach that's described throughout the information here. It's not always just a simple infection.
And that wraps up our deep dive into adult urinary tract infections based entirely on the specific revision notes we had in front of us. Thanks so much for joining us.
Thank you.
Remember, for more resources, including materials structured like these notes and other revision tools specifically for exams like the MSRA, you can check out pastthemsra.com and also freemsra.com.
Great resources there.
We'll catch you on the next deep dive.